Thank you. Our, our, my coffee will sink in, and you'll see as I become more caffeinated, we'll move along. I hope I don't need to repeat any of that. No. Okay. So, again, welcome to April's School Employee Benefits Board meeting, and our meetings are going to be held hybrid going forward. The Healthcare Authority staff will be on site, and board members and other attendees have the option of either attending on site or via Zoom. And for our Zoom attendees, our opening slide has information about how attendees can turn on closed caption subtitles. And thank you for those of you, Carrie and Donna, that have come today in person. I want to first do a roll call to identify the board members that are with us today. So let's begin. Myra Johnson. Okay, not yet. Staff, please let me know when Myra joins. Allison Polson. And we heard from Allison, I believe she will be popping in, but just so you know, she has a family matter that she's in transit for, but I'm sure she will be popping in too, and staff, please alert me. Terry House.
Good morning.
Thank you, Terry. Welcome. Pamela Cruz.
Here.
Hi, Pamela. Thank you. Carrie Schaefer.
Good morning.
Thank you for being in person. Donna Hanson-Murray.
Here. Thank you.
Thank you for being in person as well. Amy Griffin, I don't believe is expected today. Are there any others that I did not call on? No, okay. And then also Michael Tunick, thank you for attending for the Attorney General's office.
Good morning.
Thanks, Michael. And usually Katie Hatfield is our regular, and Katie is on spring break, not in Paris, I believe. But so, Michael, thank you for stepping in. And Michael also works with the PEB board, so I'm sure it's good crossover for you as well. With board members both in person and virtually, it'd be helpful for board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members attending virtually will also watch in case you use Zoom's raise hand feature to indicate you have a question. We also sometimes see some manual hands being raised, and if at the last minute you really need to jump in, please do. But staff are so good about watching and queuing up the responses. And for the public, you'll have an opportunity to provide general comments at the end of the meeting during public comment period. Dave Eisminger is going to provide an overview of today's agenda. And Dave, I'll turn it over to you.
Good morning, Chair Birch and members of the board. Dave Eisminger here. We're going to do a lot of time traveling at the beginning of our meeting and talk about all of 2022 as a reminder. And I'll also share a new direction in minutes that will produce them on a more abbreviated format, but a more consistent next meeting, reviewing those minutes kind of schedule in a few moments. We have a little bit of follow-up from some questions at the March meeting, and then everyone knows that the legislature in Olympia is still in town, but they have released some budgets. They've been passing lots of bills, and so we'll have our duo of Tanya and Cade talking about budget and bills. Then we will move into our voting action for this board meeting. Stella will be back with the policy and rules that were introduced at the prior board meeting and have gone through some stakeholder review. I made a few modifications based on some questions that were asked at the last board meeting, and we'll ask you to take action on those today. As a reminder for the public, if this is your first meeting attending, the chair will also call for public comment specific to each resolution before an action is taken on any specific resolution, and that's separate and distinct from the general public comment at the end of the board meeting. Then Stella will go through the annual rulemaking briefing to give some insights about the agency's process for all of the rules that we do within the SEB program. We have the delayed, or we bumped the presentation from last month from Molly Christie about the SEB program financial overview, and so we're bringing that to you today. So if those materials looked a little deja vu, that is why. And then we wanted to give you kind of an annual update on the Smart Health Wellness Program. And so we have our Wellness Program Manager, Kristen, here to go over Smart Health. We also periodically try to give you an overview of where we are in the status of some of our major procurements. And so our section manager, Shauna Lang, will walk through the 3 major procurements that we are in various stages of at this point. And then we will close out with some general public comment and be done for this morning.
Thank you, Dave. So with that, let's move into our next item. We need to take that vote on the approval of so I'll go through these. I did it again. Thank you. We're going to move into the vote for the March 3rd, 2022 meeting minutes. Are there comments from the board?
Chair Birch, I did want to just highlight for everyone, so it is a dense stack that is in your board materials for today, and you may be thinking about the fact that it is April 6th, 2023, and you're having before you for action approval of the March 3rd, 2022 minutes. I wanted to highlight that this packet of materials and meeting minutes is very different than the sets that you saw historically being brought for the launch of the program, which were almost, they weren't truly verbatim, but they were pretty darn close to verbatim minutes that were extraordinarily lengthy and required quite a bit of production time. That work is really immense. And Connie did an excellent job for years trying to balance both boards that were meeting on a much more, we had longer meetings, more meetings, and two boards. And that work really, as we've been looking at, has proved to be just permanently kind of an unsustainable process. So we went through and looked at the legal requirements for minutes, consulted with the other parts of the healthcare authority that support boards and produce minutes, and we began a new approach for this board season and to catch up on the entirety of last board season. So after a board meeting, we now are publishing the audio file that's being produced. And that serves more as the verbal or verbatim portion and access that the public will have. It's on the same page as the meetings and materials, which are pushed out via a delivery message to thousands of individuals who have signed up for that process. And we try to post that audio file within about a week of the board meeting. We may not hit that every time, but they'll definitely be up faster. That will give the public more immediate access to the materials and understanding of what happens at board meetings in a very fast manner. And for the record, earlier this year, we put up all of the audio files for the 2022 board season. Then Jessica has gone through, and Jessica is now supporting our board going forward, and has put together just a more truncated version that really just highlights snapshots of the core essence of the presentations. If there's clarifications that happen with a slide, a specific question, she'll capture the essence of that. But think of these as a much more traditional set of minutes that is really an overview, abbreviated overview. We have our first set of minutes in kind of what we started to settle on as a hopefully more final format for the meeting that happened last month. So if there is any feedback on that, more than happy to take that feedback as we try to refine that and settle on truly a permanent kind of template going forward. The goal here is really to balance speed and comprehensiveness. Timeliness, we've kind of sacrificed a little bit too long over this past year, and we're just trying to strike a better balance of getting public access with the audio file with a more traditional set of summary minutes. And so I just wanted to provide that context for the board.
Thank you, Dave. So we will again move into this approval of the meeting minutes, and I think we're trying to also keep our staff sane because I know this really is kind of harmonizing the processes and standardizing things, and I think it's just great because we're being more friendly to the public too, to be able to find things and to just make them more standard on both SEB and PEB. So we're going to vote on 7 sets of meeting minutes for 2022 board season, as Dave said, and as well as minutes from our March 2nd meeting. There will be a vote for each set of meetings. Since I was not in attendance, I won't be voting, but I will be coordinating throughout. Minutes are behind tab 3, separated by those goldenrod sheets of paper. And I think we'll get going. So, any questions about that process change from anybody? All right.
And real quick, Chair Rich, I thought we should do a check-in if any new board members have added.
Allison joined us.
Oh, great. Welcome, Allison. We're glad you could
Good
join
morning.
us. Thank you. So we are going to go back into the approval of these meeting minutes. We're going to begin with the March 3rd, 2022 meeting minutes. Are there comments from the board? Not hearing any. Do I have a motion to approve the minutes as written?
So moved.
Thank you, Carrie. Is there a second?
It's Donna. I'll second it.
Thanks, Donna. All those in favor say aye.
Aye. Aye.
Aye.
Thank you. Are there any opposed? Dave, and I'm not hearing any opposition. Any abstentions? And I think we'll note throughout that the chair is abstaining. The March 3rd, 2022 minutes are approved as written. Okay? We're going to get into a pattern here. April 7th, 2022 meeting minutes are our next voting item. Are there comments from the board? All right, hearing none, do I have a motion to approve the minutes as written?
So moved.
Thank you, Carrie. Is there a second?
This is Donna, second it.
Thank you, Donna. I think you two are going to be my duo today. All those in favor say aye.
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 Any opposed? All right. The April 7th, 2022 minutes are approved as written. Now let's move to the May 5th, 2022 meeting minutes. Again, are there comments from any board members? Do I have a motion to approve the minutes as written?
This is Carrie, so moved.
Thank you, Carrie. And is there a second?
This is Donna, I second it.
Thank you. All those in favor say aye.
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 Thank you. Any opposed? Hearing none, the May 5th, 2022 minutes are approved as written. We'll move on to the June 2nd, 2022 meeting minutes. Again, are there any comments from our board? Hearing none, do I have a motion to approve the minutes as written?
This is Donna, I motion.
Thank you, Donna. They're just wanting to see the level of my caffeine status. Is there a second?
This is Carrie, I second.
Thank you, Carrie, for that second. All those in favor say aye.
Aye. Aye.
Terrific. Are there any opposed? Hearing none, the June 2nd, 2022 minutes are approved as written. Now we'll move on to June 23rd, 2022 minutes. Again, are there any comments from the board? All right, hearing none, do I have a motion to approve the minutes as written?
This is Carrie, so moved.
Thank you, Carrie. And is there a second?
This is Donna, I second that.
Thank you, Donna. All those in favor say aye.
Aye. Aye.
Online?
Aye.
Thank you. And is there any opposition? Hearing none, I am suggesting that the June 23rd, 2022 minutes are approved as written. We'll move into July, the July 7th, 2022 meeting minutes. Are there comments from the board? Hearing none, do I have a motion to approve the minutes as written?
This is Carrie, so moved.
Thank you, Carrie. Is there a second?
This is Donna, I second it.
Great. All those in favor say aye.
Aye. Aye.
Aye.
Thank you. Any opposed? The July 7th, 2022 minutes are approved as written. We'll move into the July 21, 2022 meeting minutes. Are there comments from the board? Hearing no comments, do I have a motion to approve the minutes as written?
This is Donna, I approve the minutes as written. I make a motion to approve the minutes as written.
Great. Thank you, Donna. Is there a second?
Second.
Thank you, Carrie. All those in favor say aye.
Aye. Aye.
All those opposed?
Aye.
I believe that was a delay approval.
It was.
Thank you, Allison. It's that, it's that distance between here and Spokane. All right. Hearing no opposition, the July 21, 2022 minutes are approved as written. And lastly, we have the March 2nd, 2023 minutes. This is the new format of minutes that Dave described earlier and the intended format going forward. And so I'll just give you a minute to please look at this and provide any feedback on their structure from the board would really be appreciated now. So if you want to just take a minute and look at this new format. So board members, do you have any comments or feedback for staff? All right, I'm not hearing any, so do I have a motion to approve the minutes as written?
Carrie, so moved.
Thank you, Carrie. And is there a second?
This is Donna, I second it.
Thank you, Donna. All those in favor say aye.
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 Great. Any opposition? Hearing none, the March 2nd, 2023 minutes are approved as written, and I'm glad we could get through that, Dave. Thank you all, especially Carrie and Donna, for doing that work. All right, we're going to move on to our next agenda item, the March meeting follow-up. Dave, go ahead, and everybody knows Dave. He's our Employees and Retirees Division Director, and he's going to provide some follow-up details from the inquiries asked during the March board meeting. Dave's materials are behind tab 4. I believe there are 6 slides there for us to review, and I'll turn it over to you.
All right, good morning again. I almost said Chair McDermott, Chair Birch, and members of the board. What additional thing that you'll notice that has changed beyond the meeting minute formats is the look of your slide decks. If you hadn't noticed, we changed our agency process sometime last year, and we're catching up here in the PEB and SEB programs with using this new format, but we are keeping this color scheme for you, this teal and goldenrod. For us here at the in the division administering 2 programs, visually seeing 2 different color palettes has proved crucial in being able to keep things straight between the boards. But just wanted to give you an acknowledgement of this new format that hopefully makes things a little bit overall easier to see on our slide decks. So going in, there were a few questions. Every time that there are board meetings, some questions result in presentations at later points in the board season. Sometimes they're integrated within the materials of a presentation of that day, but sometimes there's just kind of cleanup pitching, and that's what I'm doing today. So there were a few pharmacy questions in particular, and so on slide 2, the main question that was coming up was in the context of customer satisfaction in the Uniform Medical Plan, particularly in the retail setting, and what type of metrics we had that related to customer satisfaction. And so the full answer there is, UMP does not do, or it isn't really able to conduct specific customer satisfaction surveys at individual network pharmacies, but wanted to bring a little bit more information about that. But there is not specific targeted customer service surveys of individual retail pharmacies within the network. So looking at slide number 3, part of this is really due to the size, scope, and diversity of the network and how much a retail pharmacy can come in and out of the network. On this slide, the first sub-bullet is about UMP, and then we thought we should describe some things about Kaiser, as there's been a lot of questions about Kaiser's pharmacy, especially in the past couple of months with that shift to mail order pharmacy. So we wanted to give a little bit of compare and contrast there. But that size and scope and diversity just made it very hard in the UMP setting to be able to have some sort of standardization process. Kaiser does do this within their program and plans because they are using a single mail order integrated within their delivery system that is serving the entire population. It's also important to know at the second part of the slide that this isn't part of the network contracts for a pharmacy to be in network. That's not the contract that the healthcare authority holds. It's with the individual carrier or plan. So that's something that we can explore to talk about how to get these types of things, but that's not something that's currently a contractual requirement for network status. So the pharmacies are not paid to collect this data. And when there is some sort of comprehensive customer survey, that does get added costs within the contract. So it doesn't exist today. At the same time, though, again, the integrated model that Kaiser has allowed them to factor that into the process with mail order pharmacies, so they do that type of survey within their system. So what data do we have, moving on to slide 4, about customer satisfaction within the Uniform Medical Plan? As a reminder, it's called the Uniform Medical Plan. Many people will say, I have Regents, or a few people will say, I have Regents and MODA, because Regents covers and does the administrative services for the medical benefit within the plan, and MODA is doing the coordination of services for the pharmacy benefit. But it's all the Uniform Medical Plan. So MODA is the pharmacy side of the equation. There is an annual survey of members who interact with MODA's customer service. You think of most people are interacting with customer service when they need help or assistance, so that's the perfect opportunity to try to gauge in those instances how they're feeling with that customer support. And in 2022, that satisfaction rate was 92% of UMP members. Now I'll say that is a combined number for both PEB and SEB UMP. indicating that they were either very satisfied or satisfied with the support and service that MOTA was providing. So a little bit more about that survey is on slide 5. I won't read through all of it, but it was a 2-month survey in the summer of 2022, a little over 450 members, again, combined for the PEB and SEB programs, and you're seeing there how it get to the 92% satisfied or very satisfied. There is an opportunity for people to leave individual comments, and so then those are reviewed by MOTA and also our contract managers here at the Healthcare Authority that oversee the contract with MOTA. And then just wanted to note, well, what are people calling about that they're needing support from? And so we wanted to highlight it's prior authorizations, just general benefit information, what is this drug covered, not covered, what types of copays might there be, the network status of a pharmacy, and then also pricing. So again, those copays, cost shares, what can I expect to pay as a member? So those are the types of things that people are calling about. Wanted to just not simply say we can't do that survey because, wanted to give you information that we do have to be able to share and give some insight about the way that our members are interacting with UMP Pharmacy. And so that's what I have back for that question from last meeting.
Great, thank you, Dave. Members of the board, any questions for Dave about that follow-up item? And I trust that staff will look into how we could get deeper into satisfaction at the direct purchase site. All right, let's move on to our next agenda item, the 2023-25 budget update. Our very own Tanya Duell, good morning Tanya, who is our finance manager in the Financial Services Division, is going to provide that update on the latest with the biennial budget proposal introduced recently in the legislature. Her materials are behind tab 5.
Good morning, Chair Birch, members of the board. For the record, my name is Tanya Duell. I am the Herb Finance Manager here at HCA, and I'm going to give you a quick update on the status of the budget. All right, first we're going to talk through the proposed funding rates. So before I get into those numbers, I just wanted to note that all 3 versions of the budget funding rates are adequate to maintain our current level of benefits, as well as satisfying the additional funding required within the collective bargaining agreement, and those are paid on a per employee per month basis. So on this next slide here, you'll see the funding rates for both of the school years within the next biennium. I walked through the governor's proposed funding rates during the board retreat, and since then, in the last 2 weeks, we've received both a Senate proposed and a House proposed budget. Both of those budgets have funding rates that we believe fully meet the requirements to fund the program plus the collective bargaining agreement. We have no concerns with any of the underlying assumptions. One thing I want to note that happened between the governor's and the legislative proposed budgets is the legislative budgets relied on an updated model that we delivered. We run our modeling every quarter, and we deliver those model updates to the legislature and OFM every quarter, which include an additional 3 months of experience, as well as enrollment updates or any other known financial changes we have within the program. So those 2 recent budgets did rely on an updated quarterly model.
Real quick, Tanya, I just want I'll highlight for everyone. There's this time of year, Tanya and I, one of maybe the top 5 questions we get is, what number needs to be in the budget? And we like to say there is no magic number. It all is a basis, includes various assumptions on either trend or what surplus or deficit position the program should be in. And so it's very purposeful that Tanya says we don't have concerns about what we're seeing. If there's no signal here to cut benefits, there is support for any benefit enhancements that are coming. That's why she's very deliberate. But we always get asked, which number is the right number? There is no right number. It's all about the model and the assumptions. And so it's very purposeful. So we like to say there is no magic number. Just wanted to highlight that again.
That's correct. Thanks, Dave. Yeah, no magic number. We are comfortable with all of the numbers you see here on your slides. As a reminder, our SEB program spends about $2 billion annually. So a slight change in numbers is a very small percentage in overall spend. On the next slide here, I have the proposed similarities between all 3 versions of the budget, the governor, the Senate, and the House proposed budgets. These numbers you see here are biennial amounts. So with some of these benefit changes being on a calendar year, some of these estimates or the numbers here on the screen are either 18 months or even just 6 months. So we'll walk through those. Up first is around $11 million, 11.1. of our self-insured third-party administrator, TPA. This is our spending authority. As we receive increased enrollment in our self-insured medical and dental, we have to ask for additional authority to spend funds out of those administrative accounts to pay both Regents and MODA and Delta Dental for our self-insured products. You will see me probably mention this every single budget update as we just continue to update with our self-insured enrollment projections. Next up is the Uniform Medical Plan Diabetes Management Program. So starting January 2024, we received $860,000 for 18 months of the biennium for an app-based intervention available to members, which would meet certain eligibility criteria to use for a diabetes diagnosis. This is different than our current diabetes prevention program. This is a diabetes management program for those who actually have a diabetes diagnosis.
Tanya, it's type 1 diabetes for this program, or is
Type-
it both type 1 and type 2?
Primary.
I-
The programs that are looked at are typically focused on type 2 diabetes.
Okay, thank you.
All right. And next up is a vision enhancement. This is starting calendar year 2025, so this would be 6 months within the biennium. So this is a vision enhancement to hardware, increasing the allowance from $150 to $200 every 2 years. So $2.8 million for that 6 months. And then next up is the Uniform Dental Plan dental benefit enhancements. As you remember, last year we had a lot of conversation around the various dental enhancements that were possible and how the board wanted to prioritize that funding request. So of that total request, there was $12.7 million funded for, that's 18 months worth of the biennium starting January 2024. And I'll walk through on the next slide which of those components equal that 12.7. And I just want to note, since I spent a lot of time during the retreat talking about the collective bargaining agreement and the additional funding that was added into the collective bargaining agreement, that additional $6 investment. The last three items on that slide, the diabetes management program, the vision enhancement, and the dental benefits, those three items combined satisfy that $6 requirement in the collective bargaining agreement. And those three were the same within the governor, the Senate, and the House budget. So I just want to be clear that those three items equal that $6. On the next slide here, as you can see, the check marks in the box shows perfect alignment between the governor, the Senate, and the House budget on which items were funded of our overall decision package request. Our total decision package request equals the dollars on the bottom, but the items with the check marks equal the previous slide. So the items that were included in all three versions of the budget are the composite coverage for posterior teeth fillings, eliminating the deductible for children up to age 15, increasing crown coverage, and I do want to note in our decision package we did have various levels of crown coverage, and this was at 70% the funding. And then also increasing the TMJ annual and lifetime benefits here.
This is Dave. Just a little bit more as a reminder, the crown coverage today in the Uniform Dental Plan is 50% as a Class 3 benefit. The decision package had levers up to 60, 70, or 80%, but what was picked and funded in the budgets was 70%. So that is a significant increase. It was the midpoint of the proposal. And the TMJ annual lifetime benefits, if I remember correctly, is going from $1,000 to $5,000. If there are other questions, we'll certainly bring some information back to the board as we're preparing for implementation of these. But just wanted to remind people about the current coverage of those two. And the deductible is $50 today, and that would be eliminated.
I'm sorry, Dave, can you repeat the increase in the crown coverage?
Yes. So crown coverage today is 50% by the plan, 50% by the member, and then this would shift to 70% by the plan and 30% by the member.
Thank you.
I know that will be a welcome benefit increase. As board members know, and the Healthcare Authority knows, one of the areas that we hear the most about from school employees is differences in dental plan coverage pre-SEB to SEB, and this certainly brings this part of the portfolio a little bit closer to what I think people are hoping to have. It might not be everything, but it's definitely an important step.
All right, next up, the last slide here shows really the only difference between the versions of the budget. In the most recent Senate version, we have a proviso, which means you have to spend those dollars on that specific item. So $324,000 for the implementation of Substitute Senate Bill 5275, which would expand the access to benefits provided by SEB. I'm sure Cade will talk a little bit about that up next. Dave, do you want to add anything before Cade?
Two things. It's not unusual for proposals to differ, the legislative budgets to differ. They focus on bills that have come out of their chamber when they're looking at their budgets. So, and there are many times where agencies and the PEB and SEB programs and the Healthcare Authority in general are charged with implementing something without additional budget provision language expenditure authority. We just have to implement within existing resources many times. So you can't really read into things that a bill's not there. It's a good indicator that a bill's likely to pass if it does have a specific provision like this, but it's not unusual to not see House bills in the Senate budget proposal or vice versa. This bill is about creating what we call the employer group process, and K-12 school districts are very familiar with this because prior to the SEB program, there was the ability to join the PEB program voluntarily as an employer group. This sets up a similar process for the SEB program for elected school board members, tribal governments, and organizations that represent school employees. So it's very similar to the process for the PEP program, but just allowing access on a voluntary basis for those K-12 related entities. And Cade will share some more about implementation when we get to his presentation.
All right. Thanks, Dave, for that additional context. So up next, session goes through April 23rd. So I will be here at the next meeting, hopefully with a budget update for you on the final conference budget. I think that we could read through the tea leaves and assume that where things are in alignment in all three budgets, we assume will be within the final conference budget, but just don't know, so I'll give that update when I'm back next month. And then any additional proviso languages or things that are new between the final conference budget, I'll give that update and the final funding rate numbers. So all in all, I think we're in a good place with the alignment with all three versions of the budget. Any questions?
Tanya, thank you for
Thank you.
that presentation,
Yep.
and I know you and Dave and the entire team have been on deck and answering questions and navigating through the legislative period, so thank you. I
Yeah.
would agree we're in a strong position, but we're
Yep.
fingers crossed till the
Anything
end.
can happen. Thank you.
We'll see you next month. Thank you. All right, and we will move right into the legislative update. And Kate Walker, who is our Policy Rules and Compliance Section Manager in our ERB division, is going to share those updates on what's happening with bills that we've been tracking in the 2023 legislative session. Kate, welcome.
Thank you,
Good to
Chair.
see you in person. It's been a while.
Likewise, good to see you and members of the board. Again, Kate Walker here to provide you another round of our legislative updates. We'll get right into things here and show you kind of the work that we've been doing, busy as bees in the ERB division, supporting and working with other divisions in the agency to make sure that we are being active participants in the legislative review process. You can see here to date, well, this is as of the 27th of last month, but we've done close to 200 bill analyses so far. This was 188 as of the time that we got these slides turned in. We've had quite a few that ERB has been a lead analyst on, and just for the purposes of how we parse up all the work that we do. You know, the agency has a lot of bills that come through. We have the Apple Health program the behavioral health and PEB and SEB programs, and we are responsible for the PEB and SEB bills. They're going to be most impactful, but we also review a lot of bills just to make sure that we're reviewing and saying, is this going to be impactful to the programs or is it not? So that's why you'll see a lot of low priority ERB support bills, where we assign it a low priority, that it doesn't have any impact on our programs, that we're tracking it, just making sure that if there is anything that does change in that legislation, that we're following it, just to make sure that we are tracking all the different little possibilities that may have impacts on our programs. When we do review legislation that does have impacts on the program, whether those are financial impacts or they're impacts that would impact or legislative changes that would impact our rules or our policies, or have some sort of implementation effort that would be required of our programs, then we will assign it a high priority. And the bills that we are assigned by the agency to be the lead on, because we are the division that has the most impacts of any legislation, we will take the lead on. And so some of the bills that have already talked about in the budget are bills that are ERB high priority lead bills that we track. Those are the ones that we keep a very, very good focus on, because there's the potential for that to have a lot more impact on our programs. Also, just noting the fiscal notes, Tanya and her team have done a fantastic job. A lot of fiscal notes this year. I think for our program it's up close to about 90, which is a substantially higher number than we've had in prior years. So great job for the finance team and our team as well, because that the process when we have a fiscal note that comes through, we have an accelerated time frame of our analysts to get that work done. So they have to get their bill review done, they got to read through the legislation, they have a report they need to fill out, they have to have it reviewed by at least 2 managers before it gets approved and sent to the agency for their review. So a lot of work that gets done for this, a lot of thousands of hours worth of work in that chart, which is why I like to kind of highlight it a little bit. Next slide, please. We have our funnel of how a bill becomes law. This is, again, a little outdated from where things have been moving, because things have been moving rather quickly. But you can see here we are on the 6th today, so we made it past the opposite chamber fiscal cutoff. There are about 8 bills that we are tracking that are high priority ERB-led bills that are still in motion, 4 of which have actually already made it to the governor's desk, 2 possibly more that have already been signed, but at least 2 that have been signed already, and we'll talk about those in just a second. Next slide, please. So a little bit on the requested legislation. 5700 was legislation requested by the agency that was primarily a statutory cleanup piece of legislation, very extensive, taking all of the different components of legislation of statute that have been combined and consolidated into the HCA program, HCA agency over the last few years, cleaning up a lot of language in there, making sure that pronouns are all adequately or appropriately addressed, and the definitions are being cleaned up, and language modernized, I guess would be the best way to do it. A little bit of policy stuff in there, but that wasn't anything that would impact the PEB or SEB programs. And so that has passed, which is nice because it allows us to kind of have these statutes cleaned up, which will then allow us to do some cleanup on our rules and policies so that the language is easier and all copacetic. We also have Senate Bill 5421. While this is not what we would consider regular requested agency legislation, this was legislation, just as a reminder, that came about because of CMS requirements for the Medicare Advantage sponsors to collect on a voluntary basis the race, ethnicity, and language data. It allowed us an opportunity to say, well, we need to make sure that that information is protected, and also while we are at it with the creation of Benefits 24/7, that is the launch pending, and I think we'll have, is it on the agenda for today?
Not today.
Not today. But we have SEB My Account that we're able to collect a lot of information from for the enrollment process for the SEB program. There's interest at some point in the near future starting a voluntary collection of race, ethnicity, language data for all of the members in the PEB and SEB programs through our online enrollment platform. 5421 creates a new exemption in the Public Records Act that ensures that that information and all the information that's collected as part of the enrollment process for PEB and SEB for both employees, for retirees, for COBRA enrollees, anyone that utilizes PEB or SEB program services, that information that we collect for the enrollment process is protected from disclosure, which then gives us a really great opportunity to start collecting information that might be considered more sensitive by the members. And that way, when we are, we're able to assure that we can collect that and have it protected from disclosure, that we can then use that for addressing health inequities and other equity issues that may be discovered. But we don't have the data to really get into that. So this legislation is really one of the big hurdles that we had to overcome in order to start that process of collecting race, ethnicity, language data. And I think we'll have more on that in the future. Dave's tasked me with the work of not necessarily, there's nothing to implement about SB 5421, but the effect of that allowing us to begin the process of collecting race, ethnicity, language data is what he's tasked me with. So I'm sure there'll be an opportunity in the future to discuss those efforts and the impacts on health equity and equity in general for our programs.
Dave here. A couple more things about this bill. It's just interesting. as the legislative review of it was going on, a lot of people were like, I thought this was protected information already. And it's always very challenging which hat the healthcare authority is wearing. We're a plan administrator, we're a plan sponsor, we're an employer. And sometimes with these programs, we actually are administering benefits on behalf of 750 other employers. And so one of the questions that came up was, I thought that this stuff was in a personnel file that was already exempted under the Public Records Act. Well, that would be true if we were the actual employer, but we're not always the employer because we're acting on behalf of all of those employers. So it really was just this kind of weird space where it was information that everyone thought would clearly be protected. It just didn't have the nicest, cleanest exemption authority. And so this is really kind of an exciting piece of legislation to kind of tick and tie all of that up in a row. And it's actually under the bill signing review process with the governor, literally right now. He's doing action on various bills, and both of these on the slide are up for action today in the governor's office.
Dave, this is Sue. I want to really applaud you all on this effort. The most recent community checkup report out from the Washington Health Alliance really starts to validate the issues that we have around DEI and health inequities, especially as they've overlaid the area deprivation index zones and showing kind of just the enormous health inequities and how we really have to continue to understand and support strengthen our DEI efforts around creating more uniformity of services and providers, and just it's really a remarkable report, and we have lots of work to get going on. So this allows for the beginning of that data protection, and thank you all for advancing on this.
Thank you. Yeah, exciting work to come. I'm excited about it. It's something I get to work a lot on with our health equity team here at the agency, and so this was we didn't think about I'd say last summer as part of the SEBB collective bargaining agreement work group on equity. We recognized that data collection was going to be a significant hurdle, and privacy was going to be one of those significant aspects of that data collection effort. So we recognized that there was going to need to be some legislation passed in order for us to really ensure that this was protected information. And but it was one of those efforts thinking, well, that's going to be probably next year because we're going to do agency request legislation, get it through the process. It was going to take us a while. And then this kind of CMS launched their requirements to collect this information that came after our process timeline for being able to do agency request legislation. And so we took it as an opportunity. It's like, well, this is a kind of a real nice gift for us to say, well, we need to do this absolutely because of CMS requirements, and it allows us to get a jump start on getting that protected for the rest of the program and enrollees. And so we took it as a real opportunity to move quickly, get legislation drafted in very quick time. Our team did a great job at drafting an exemption in the Public Records Act, which is not a small feat in and of itself to have it get passed through with almost little to no opposition, just a little tiny bit of question about what was going on. So really, I think a fantastic effort by the team that's going to open up a lot of opportunities for us to really start diving in, as Chair Birch mentioned, and working on equity issues in our programs and in the larger system as well. Next slide, please. So moving into the topical areas of legislation and more specificity, as was mentioned a little bit ago about Senate Bill 5275. This is the SEB Benefits Access, the SEB Employer Group legislation that has been signed by the governor. So we have already began the implementation process of that legislation. It goes into effect January 1 of next year. However, we know that if there are to be any employer groups that would be interested, any tribal schools, any of the representation organizations for employees or school board members that want to join SEB effective 1/1 of 2024, that process will need to be started several months beforehand. So we're getting that process put into place, having our rules. We're beginning the rule drafting process for this bill and any of the other pieces of legislation that have time frames of implementation that are much sooner than our rule process would normally allow, which would be 2025 under our regular cycle. We will be filing emergency rules for these pieces of legislation that have a different process than the regular rule process that we go through or that the APA, the Administrative Procedure Acts, requires. So emergency rules allow us to have those implemented in short order, which for 5275 is not as necessary, but certainly for 5490, which is the next bill I'll talk about, it is absolutely necessary for us to have emergency rules. So 5490, Just to wrap up on the process for 5275, at the next board meeting, I will be giving a presentation about a lot more of the implementation efforts on all the legislation that does have implementation work that needs to be done right now and ahead of the end of the year. 5275 doesn't have anything, like I had mentioned, that requires immediate work to be done, but we intend to have things, the process all ready to go for any of the groups that would like to join in the next few months, so they can join and be able to select benefits during hopefully the open enrollment cycle, and be ready for joining the SEB program by 1/1 of 2024. Moving on to Senate Bill 5490. This is what we've kind of referred to as the nibble at the apple, as a little takeoff of on the second bite at the apple for retirees. This has been an issue that we've known about for a long time in the PEB program, that there are retirees that for various reasons aren't able to enroll in retiree coverage, whether that's because they failed to defer their coverage when they separated from state service, or they did not meet the substantive requirements, they didn't meet the eligibility requirements for retiree coverage benefits. So there's a lot of different reasons why there's a substantial population of retirees that aren't in PEB coverage that had some eligibility at some point or other. 5490 provides a very narrow path for some of those retirees to come and have a second opportunity to enroll in retiree benefits. That is effective. It did have an emergency provision in that legislation that it was effective upon signing. So as of last Thursday, it was effective. And so any of the retirees that meet the requirements to come back and enroll in retiree coverage are able to do so as of last Thursday. The requirements there are very, very narrow. In fact, there's three narrowing qualifications for it. The first is that they had to have been denied. The retiree must have been denied access to retiree benefits because they did not submit a deferral form when they retired or they separated from state employment. That's a form that's required if they do not intend to enroll in coverage immediately upon separating from state service, or if they're not drawing their pension. They don't meet certain definitions, then they need to submit a form. That form is necessary. It also informs them that they have to maintain credible coverage in insurance during their time that they separated from state employment and when they want to come back for benefits. And so if they did not submit that deferral form, and that was the reason why they weren't allowed to come back, then they moved to the next step of eligibility, which did they file an appeal with our appeals office. And if they did file an appeal and they had been denied that deferral and they're eligible for Medicare, then they're allowed to come back. So we think this is a very, very narrow population. We're currently trying to pull data so that we can identify the population as best as we can. There's no limit going backwards for this, although we know that the deferral form came about in 2001, and so we know it's as far back as the lower end is 2001, and it's all the way up through that appeal having been filed for the denial of benefits as of December 31st of last year. So we have between 2001 and 2022, any of the retirees that met those three components of eligibility would be able to come back. We think it's a very small number, but we're working on the data to identify them so we can reach out to them. We're also going to be engaging with different retiree groups to try and have them help us identify anyone in their population. What we don't want to do is cause a significant number of people to start rushing back thinking they can come back to benefits when we know it's a very small population. So we're trying to be more targeted in our approach to this so that we're not giving false hopes to a lot of individuals who think they're going to be able to come back for benefits, and also not overburdening our staff with a lot of denials that they're going to have to make, which then would likely result in a lot of appeals that would be filed. And we're just trying to make sure it's very clear who we're reaching out to and who would be eligible for this. That is something that, again, had an emergency enactment clause, so we're working right now on implementing that. I'll have more information at the next meeting. Suffice to say that we are going to be filing emergency rules for that as well. It does have an expiration date of the end of this year, so if members haven't applied to return to retiree coverage actually it's the end of November. If they've not applied to return to coverage by the end of November, then that opportunity has lapsed for them.
Dave here, just to again highlight something, that this particular issues that Kate was describing about accessing the deferral rule, in the timely manner with the form did tend over the years to disproportionately hit the K-12 system. I always said when SEB was created, the bridge to PEB would be that much more apparent for K-12 members as they retire. And that has proven to be the case. We do see a strong enrollment, an uptick in the overall transition for K-12 into the PEB retiree benefits. But for that 20 years where that deferral form, give or take a year or two, that existed pre-SEB, it's just there are more individuals that failed to meet the deferral form that are disproportionately K-12. So just wanted to highlight that for this board.
Thanks. All right. I'll try and zip through the rest of the legislation that's still moving. We have House Bill 1008 regarding expanding the definition of a separated employee to include those in a Plan 2, PERS, TERS, or SERS, or PSERS retirement plan. What that means is that we have an opportunity for employees in Plan 3s that if they separate prior to drawing their pension after age 55 with a minimum number of service hours, they're eligible to enroll in retiree coverage. That definition does not currently include Plan 2 members or Plan 1 members for that matter. Sorry, Connie. But I think you'd have as much a concern there. So it will expand that to include Plan 2 members, which will give them the opportunity, if they separate from state service prior to the time when they'd be drawing their pension, that they'd be eligible to enroll in retiree benefits, again, prior to their drawing a pension. We have House Bill 1804 and its companion 5696. This is legislation that is addressing an issue that popped up last year with a couple of employer groups that had been leaving the PEB program. Again, employer groups are allowed to participate on a voluntary basis. They get to choose when they come in, and they have the option on when they would leave. When they leave, what will happen with some of with the retirees that they have, they're allowed to bring retirees with them if they meet certain criteria, and they're allowed to have the employees they have that retire while they're participating in PEB, and will also be the same case with SEB. They can bring their have their retirees retire and go into our retiree pool as long as they're still participating in the PEB or SEB program. However, when they choose to leave, their retirees also go with them, as well as their disabled employees go with them. We have discovered that there are situations where some of the employer groups will not provide any coverage or any benefits for those retirees when they leave. And I know, same face I have, Dawn. I'm not sure why, but they don't go. They don't have coverage that is affordable for them. They might provide something, but it is 3 or 4 times what they were paying when they were with the PEB program. So we were asked to draft legislation that would allow those retirees to remain in PEB retiree coverage. Now, there's actually a few components of the bill. The first part of the bill allows for any of the retirees from an employer group that left as of December of last year, that for these particular employer groups last year that had left and they lost coverage from the PEB program, that they're allowed to come back. We're going to say, all right, you did lose your coverage then, but you're allowed to come back. That has an emergency enactment clause, so if that passes, which we think it will pass, it's had no opposition so far, that when it passes, it will become emergency effective, and any of those retirees who lost coverage because their employer group left, they'll be able to return to the program. They'll do so on a rate that's different than they've been paying before. They'll be paying what we refer to as the self-pay or COBRA coverage rates, because there's no subsidization that will be coming from their employer, nor will they have access to any of the subsidization if they're a pre-Medicare retiree that they get as part of being part of the active risk pool. The second part is that it allows for any of the retirees for employer groups that leave moving forward, that they're able to remain as well. That's for any of the grandfathered employer groups that participate currently. And then the third part, which is a little bit more complicated, and we're going to see how it rolls out, is that for any employer group that joins after the implementation of the legislation, or after the execution of the legislation, if they join after the date the governor signs the legislation, and then they leave after that point, and they have to be in for a year, and then once they leave, their retirees can stay just like the other retirees, but the employer who's leaving will have to pay a lump sum amount that is equal to the subsidized amount of being in the active risk pool for that employee who decides to stay for the duration that they would be in the non-Medicare risk pool. Now I think that's a lot of words. It's saying there's an actuarial subsidy that occurs in the active risk pool. So when you have retirees who are not Medicare eligible, who are participating in the non-Medicare risk pool, there's some subsidization of the cost they pay because they're older population mixed in with the entire group of the active population, so there's some subsidization there. Legislators were concerned about that being a gift of public funds, so they had us draft legislation that says, all right, we're going to make sure that the actuarial value of that retiree who's non-Medicare participating in the active pool, that the employer who's leaving has to pay that cost for each month that would be for that retiree until they would reach Medicare eligibility. And so if they were, let's say, 55 and they met our requirements to enroll in retiree coverage, and then there was 10 years until they're going to be Medicare eligible, they would pay 120 months of that value at that upfront leaving cost. And so that's a pretty substantial cost on the per retiree basis, depending on how many months there are. So we have language in there, and I know our finance team is working on how to be able to calculate that at that point of exit. But that's another piece of that legislation that we've recently put in that's a little on the tricky side, but I know our finance team, and we'll get that implemented just fine.
Dave here. Another big piece of that conversation was really I think Carrie can probably attest to this, that our PEB retiree pool tends to be very attractive because there are a lot of employers who don't offer retiree coverage to former employees. And so there was also concern from the legislature that employer groups could come and then leave their retirees and expand the liability of the state for subsidies both in the non-Medicare and Medicare risk pool. So this was really just trying to balance access with containing that potential liability. For the non-Medicare retirees, those who are under 65 who stay, there's this lump sum payment that the exiting employer group has to pay. And then for the Medicare retirees, they can stay, they just don't receive the explicit subsidy that other members of the pool receive. So it's just trying to balance access with those potential liabilities.
Yeah, I just want to make a comment from a coverage perspective. This really deserves great recognition because we know that people 50 to 65 are a significant population that really struggles with coverage, and for Washington to really make the commitment to keep people covered and also to kind of shift some of that responsibility to the employer so they don't just dump off their pre-retirees under 65. I just really applaud the efforts here. So thank you all for working with our legislators to keep this moving forward.
We've had a lot of good legislation this year regarding access. All of the legislation that we have is expanding and creating access for more individuals to have access to the PEB and SEB programs. And I think that's a testament to the value that people see, not only our legislature, but also the members and retirees themselves in wanting to remain in our coverage that we provide. Next slide, please. A couple of other areas. We have House Bill 1222. Actually, I think that has passed, hasn't it? It hasn't passed yet. On hearing instrument coverage, expanding the amount of coverage for hearing instruments. Senate Bill 5242. All the legislation that's not been crossed out is addressing either eliminating or reducing the cost share for those services that would have financial impacts on some of our plans that we're tracking, but nothing that has a significant administrative burden for the programs. Next slides, please. We also did have the cap on insulin cost sharing that expanded or extended the $35 per 30-day supply for insulin was assigned, so that $35 cap will continue, which I think is really great, and hopefully we'll see that on the federal side as well. Next slide, please. I haven't crossed out anything regarding the new or expanded licensures because there's a whole lot of them that are continuing to move through, and once we get to the end of session, which by the next meeting I think we'll have passed through session, so I'll have a wrap up of which of the expanded or new licensures made it across the finish line this year. Did also want to note that pet insurance 5319 did pass, allowing the Office of the Insurance Commissioner to regulate pet insurance, which I think is an important step for us to then begin an effort that this board has the authority to offer to the employees of the SEB program. That is part of legislation that was passed a few years ago, expanding the optional benefits that can be offered by this board to the SEB program. So it was put in there. We had heard from a lot of districts when SEB was being implemented. A lot of them were curious about pet insurance and had offered pet insurance to their employees. So I think there's a good number of individuals who would be very interested in the board considering offering a group pet insurance option for the employees. And again, on those optional benefits, it's always 100% employee paid and voluntary basis for them. So if there becomes a well-regulated market for pet insurance in the state, and at some point this board decides they'd like to have us consider a procurement and again study a little bit, if it were to be offered, it'd be a voluntary self-paid benefit for employees. Lastly, House Bill 1357, modernizing prior authorizations, is moving. There's a lot of moving components to this, and the agency is tracking it very closely. If this does pass the finish line, we'll bring back more information on that because and probably have our clinical team address that a bit more, because it does have a lot of potential implications on the way that our carriers would do their prior authorization for all the members, and we'd want to probably expand on the conversation about that in the future.
This is Dave, for the record. At a high level, some of the things that it does is it kind of shortens some of the turnaround times in certain instances and requires more electronic prior authorization processes, and includes certain benchmarks. Again, they floated, so I'm not going to get the details right, but something like if X percent, and X is a really high number, are always approved, then remove prior authorizations. If there are so many prior authorizations that it's almost as if they're automatically being approved, then eliminate that prior authorization for that specific service line. So there's a couple of moving parts there, but it is about basically administratively shortening timelines, getting approvals through faster, especially for those where the data suggests that a prior authorization has little utilization management value. That's a very, very high level on a bill that has a lot of moving parts, but we will definitely bring back detail on the final version. I think there's been 7 or 8 versions of it so far. So,
thanks, Dave. All right. And with that, I happily answer any questions. Otherwise, we'll be looking forward to giving you a wrap up at the next meeting.
Board members, any questions for Cade? I will just remark that there are some significant just advances on policy excellence in this area. And it's really remarkable, the strength between HCA, SEBB, and kind of setting health policy for the state. You guys really remain a leader in pushing kind of the edge and doing the right thing. That insulin policy is just extraordinary, decades in the making. And this prior authorization is a clear example of like, how can we get leaner and more efficient with administrative processes. So if, for example, if doctors are certified as the best of the best and they can get a pass on prior auth, it just reduces all the administrative burden. So again, I thank you for all of the work you guys keep doing to keep us on the forefront of good policy making. All right. Thank you, Cade. With that, we are going to move into the next natural progression, policy and rules development. And Stella Nye, who is our policy and rules coordinator from the SEBB division, is bringing back 4 policy resolutions for a vote today. So after Stella reviews each policy resolution with us, we'll go through that process where I ask for a motion to adopt and a second, and then I'll invite public comment on the amendments, and I'll ask for discussion from the board until we're ready for a vote. Stella's materials are behind tab 7. There are 21 slides and all sorts of appendices that are attached. So Stella, I'll take it over to you so you can begin to take us through this process.
Thank you, Chair Bursch. Good morning. My name is Stella Ng, and I'm the Policy and Rules Coordinator for the SEBB division. Here are the 4 resolutions for action today. The first 3 resolutions address continuation coverage for non-represented ESD school employees and their dependents. The last resolution addresses situations when subscribers do not live or work in the plan's service area and do not make a plan election within their required period. Slide 4, please. This slide and the next two slides are included in the presentation, so you will have them available as you consider the policies we will discuss. Slide 7. Thank you. So at the March SEB board meeting, board member Carey asked whether school employees electing SEB continuation coverage would be eligible to enroll in any medical, dental, or vision coverage, or only continue existing coverage types. We review how we initially implemented board resolutions regarding SEB continuation coverage when the SEB program was launched in 2020. At the time, school employees were only allowed to continue existing coverage types. We revised the first 3 resolutions to reflect school employees may elect to continue their existing enrollment. The original proposed resolutions are placed in the appendix for your reference. And we received no concerns from stakeholders regarding the first 3 board resolutions. Next slide, please. Here's the revised Resolution SEB 2023-01 addresses SEB continuation coverage eligibility for non-represented ESD school employees who will not be eligible for SEB benefits under the SEB program. We also added 2 examples to show what coverage a school employee may elect. Do we need to read?
Yeah, go through the examples.
Okay, so I will go through the 2 examples added to this presentation. Example 1, John had pet medical and dental coverage through the ESD group plan. He loses the eligibility for the employer contribution on January 1st, 2024 because he is not anticipated to be eligible under the SEB program. Can John enroll in medical, dental, and vision through SEB continuation coverage? The answer is no, because John is limited to what he previously had through his ESD group plan. He can only enroll in SEB continuation coverage in medical and dental for a maximum of 18 months on a self-pay basis. If John had only been enrolled in medical coverage, would he be eligible to enroll in dental coverage? The answer is no. John will only be able to enroll in medical coverage because that is what he had through his ESD. And the second example is Jenna. Jenna is a non-represented ESD school employee who was only enrolled in PEP dental coverage through her ESD. On January 1st, 2024, she is not anticipated to be eligible under the SEB program. Can Jenna enroll in medical and vision through SEB continuation coverage? The answer is no, because she is limited to what she previously had through her ESD group plan. She can only enroll in SEB continuation coverage for dental for a maximum of 18 months on a self-pay basis. Are there any questions from the board before the board takes an action?
Stella, I'm not seeing any. So we'll go ahead and move to a vote. So this is for Resolution SEB 2023-01, the SEB continuation coverage eligibility for non-represented ESD school employees not eligible for benefits under the SEB program. Resolved that a non-represented educational service district's school employee and their dependents who are enrolled in medical, dental, or vision under a group plan offered by a SEB organization on December 31st, 2023, who lose eligibility because the school employee is not eligible under the SEB program may elect to continue existing enrollment in one or more of the following SEB benefits: medical, dental, or vision coverage. These benefits will be provided for a maximum of 18 months on a self-pay basis. Is there a motion to adopt?
This is Donna Hanson. I move that we adopt this resolution.
Thank you, Donna. Is there a second?
This is Carrie, second.
Thank you, Pam. Are there any comments from the audience at this time? And for those that are listening, and I'm not seeing anybody in the audience here, commenting, and I'm not getting any hand signals online. Seeing that there are no comments from the public, are there any comments from the board to discuss this issue? I am not hearing any or seeing any raised hands, so we'll move to a roll call vote, and I'd like to begin with Myra Johnson. Okay, Allison Paulson, and I think Allison might need a minute to come off of mute. Okay, we will come back to Allison because she did let us know that she was having some connection issues. Terry House.
Yes.
Thank you, Terry. Pamela Cruz.
Yes.
Thank you. Carrie Schaefer.
Yes.
Thank you. Donna Hanson-Murray.
Yes.
Thank you. Amy Griffin. Oh, it's not expected today. I apologize. And this is Sue Birch. I vote in the affirmative. That would be yes. And I'll come back to Allison Paulson. No.
You just close this vote.
Okay. We will go ahead and close the vote. The resolution SEB 2023-01 passes. Stella, take us to the next resolution, please.
Yes. The next resolution, slide 12, please. SEB. Just a second. We have revised the resolution SEB 2023-02 that addresses SEB continuation coverage for dependents who are not eligible under the SEB program. The same edit is also included in the revised version of Resolution SEB 2023-02. Are there any questions from the board before the board takes an action?
I'm not seeing any signals, so we're going to go and move forward with this vote. So as before, I'll read this and then we'll move into activities here. So the resolution SEB 2023-02, SEB continuation coverage eligibility for dependents not eligible under the SEB program. Resolved that a dependent of a SEB eligible non-represented school employee of an educational service district who is enrolled in medical, dental, or vision under a school employee's account on December 31st, 2023, who loses eligibility because they are not an eligible dependent under the SEB program may continue existing enrollment for a maximum of 36 months on a self-pay basis. Is there a motion to adopt?
This is Donna Hanson. I move that we adopt this resolution.
Thank you, Donna. Is there a second to that motion?
Pam Cruz, second.
Thank you, Pam. Now I would like to take any comments from the audience. Again, I am not seeing any either in-person or online activity. Board members, are there any comments from any of you about this resolution? All right, we will move again to a roll call vote. I'll begin with Myra Johnson. I don't believe, okay, and Allison Paulson.
Yes.
Thank you, Allison. Terry House.
Yes.
Thank you, Terry. Pamela Cruz.
Yes.
Carrie Schaefer.
Yes.
Donna Hanson-Murray.
Yes.
Thank you. And I'm Sue Birch. I vote in the affirmative. So yes, the resolution SEB 2023-02 passes.
Slide 14, please.
Great. Stella, back to you for 2023-03.
Thank you, Chair Birch. Slide 14, please. Thank you. So we have revised Resolution SEB 2023-03, SEB continuation coverage for a non-represented school employees dependent who is already on an ESD's continuation coverage. The same amendment is included in the Resolution SEB 2023-03. Slide 15, please. Are there any questions from the board before the board takes an action?
Stella, I'm not seeing any. We'll move to a vote. Resolution SEB 2023-03, the SEB continuation coverage for a non-represented school employee's dependent who is already on an ESD's continuation coverage. Resolved that a dependent of a non-representative school employee who is continuing medical, dental, or vision coverage through an educational service district on December 31st, 2023, may elect to continue existing enrollment to finish out the remaining months up to the maximum numbers of months authorized by COBRA for a similar event by enrolling in a medical, dental, or vision plan offered through the SEB program on a self-pay basis. Is there a motion to adopt?
This is Donna Hanson, so moved.
Thank you, Donna. Is there a second?
Pam Cruz, second.
Thank you, Pam. Are there any comments from the audience? I'm not seeing any again in person or online. Are there any comments from the board? Hearing none, we are going to move to a roll call vote again. Allison Paulson?
Yes.
Thank you, Allison. Terry House?
Yes.
Pamela Cruz?
Yes.
Carrie Schaefer?
Yes.
Donna Hanson-Murray?
Yes.
And this is Sue Birch, voting yes. The resolution SEB 2023-03 passes. Thank you, Stella. Let's move into the next one, 2023-04.
Thank you. The last resolution, Resolution SEB 2023-04, addresses when a subscriber has a change in residence or employment location and do not make a plan change when the medical plan is no longer available, either where they live or where they work. I'm including this proposed resolution on slide 16 and the revised examples 1 and 3 based on the feedback from the PEP board when we introduced the PEP version of this resolution. The revised examples 1 and 3 provide clarity that the subscriber will be enrolled in the most comparable plan as designated by the director or designee. And the examples are in slide 17 and 18. Are there any questions from the board before the board takes an action?
This is Dave. I'm just going to answer hopefully a proactive question. Again, we didn't want the resolution to designate a specific plan because sometimes people will move into from a Kaiser service area to another Kaiser service area, or they'll move from a Kaiser service area to a UMP Primera area, and there's just too many variables to designate a specific plan. And I think it would, our recommendation, the way we came up with the language to bring to the board, was acknowledging that there is that variability and that the agency would just have the authority to designate the specific plan that is most comparable to what they are leaving. That way an individual isn't suddenly going from an HMO to a PPO, or it just keeps them as similarly situated as they can. So just highlighting why there's not a specific plan name in the resolution.
Thank you for that clarification, Dave. I'd like to move us into the vote. This is for Resolution SEB 2023-04, when a subscriber has a change in residence or employment location that affects medical plan availability. Resolved that after a change in residence or employment location, the subscriber must elect a new medical plan if a subscriber's current medical plan is no longer available based on either residence or employment location. If they do not elect a new medical plan within the time period allowed by special open enrollment rules, the subscriber will be enrolled in a SEB medical plan as designated by the director or designee. Is there a motion to adopt?
This is Donna, so moved.
Thank you, Donna. And is there a second?
Pam Cruz, second.
Thank you, Pam. And are there any comments from the audience? We are not seeing any activity online, none in the room. Are there any comments from the board? All right, again, we'll do a roll call vote. Allison Paulson.
Yes.
Thank you, Allison. Terry House.
Yes.
Thank you. Pamela Cruz. Pamela Cruz, she's trying to find that unmute button.
Yes, I'm here.
Thank you. We knew you were. Carrie Schaefer.
Yes.
Thank you, Carrie. Donna Hanson-Murray.
Yes.
Thank you. And this is Sue Birch voting yes. The resolution SEB 2023-04 passes.
Our next steps will be, we will issue guidance to the SEB organizations on these resolutions, and we will incorporate them into the SEB program rules. Thank you very much.
Stella, on behalf of the board, I just want to thank you for always, all your details, watching things, moving us along, keeping things progressing. So thanks to you and your team. All of this
Welcome.
housekeeping work is critically important for running this program. And Dave, to you and Stella, that's a lot of attention to detail all the time. Thank you. We don't say thanks enough. So what I'd like to do now is I think we would like to take a little bit of a break. Bio break, and for those on the phone, please stand up and stretch. We'll be back at you in 10 minutes. Where is our clock? 10:35. Thank you. Online, I hope you've got a nice stretch break. Thank you for the treats, that staff that you brought in for the board members. The coffee is always really helpful. We are going to move into our next topic, the rulemaking briefing, again by Stella Nye. The Policy and Rules Coordinator in the ERB Division is here to go over the annual rulemaking briefing with us today, and her materials are behind tab 8. Stella, over to you.
Thank you. Good morning. Good morning, Chairperson, members of the board. For the record, my name is Stella Ng, and I'm the Policy and Rules Coordinator for the ERB Division. I'm going to go over high-level information on this year's rulemaking and highlight the most significant changes and rulemaking actions we are considering making. No action is needed from the board for this briefing. Next slide, please. Yes. These are the tentative date for our rulemaking timeline, as we are also working on some parallel rulemaking due to legislation. So in June of 2023, we plan to file proposed amendments, CR 102, and distribute new rules for public comments. In July, we will conduct public hearing and adopt final rules so that all the permanent rules will be effective January 1st, 2024. Next slide, please. The focus of this year's rulemaking is divided into 3 different areas. We will implement SEB board policy resolutions that are passed by the board just earlier this year, and then we are also working on rules related to several bills that have passed during this legislative session. We are adding clarity to rules to better administer and manage SEB benefits as identified by staff and stakeholders, and we are making changes to comply with federal requirements. Next slide, please. Under implement legislation, we are amending rules to include non-represented ESD school employees, as this population will join the SEB program effective 1/1/2024. That was from Engrossed Substitute House Bill 2140 that was passed by the legislature in 2019. And Kay just went over the rest of the bill extensively in his presentation, so I will skip the rest and go over administration and benefit management section. Slide 6, please. Under administration and benefit management, we're adding a new enrollment event when HCA determines there is a substantial decrease in the providers available in a SEB health plan.
This is Dave. I want to add a little bit of, I feel like my word of the year is context, on this one. Your many school employees and board members are aware of some very prominent provider network negotiations and disputes that are becoming more and more public over the past few months. And one of the key questions that comes up in those instances from both members and benefits administrators at school districts and PEB employers is, what's the healthcare authority going to do to allow me to switch plans? And the first answer is always, let's see how the negotiations go, because the vast majority of times a network agreement is reached, and so then there is no actual termination, and thus there is no reason to whiplash a member in and out of benefits. But this rule will set the stage for people to for benefits administrators in school and state employees to understand that if a termination actually happens, HCA has the authority to initiate a special open enrollment. This is not an open enrollment that the member would initiate based on their individual belief about a decrease in the provider network, but the agency would be able to set up a large-scale open enrollment in an instance where there is a substantial decrease, such as a major provider actually going to termination mid-year. Stella?
Okay. We are amending special open enrollment rules to add a notice requirement for a SEB organization when a school employee experiences an event that creates a special open enrollment event. Next slide, please. And we are adding additional rules to implement SEB 2022-01 when school employees returning to work from active duty. Next slide, please. Yes. Under regulatory alignment, we are amending rules to include details when a school employee has a carryover amount from their medical flexible spending arrangement, FSA, in the previous plan year and enrolled in a high deductible health plan for the following year. There is a slight variation in this slide because the PEP program uses consumer-directed health plan for the same plan as the high deductible health plan. And that concludes my presentation. Are there any questions from the board?
Stella, I'm not seeing any. Thank you for the information you've provided, and we will see you back in the coming board meetings.
Thank you.
All right, let's move into our next agenda item, which is the SEB program financial overview. Molly Christie, who I do not see here, and maybe she's online.
Yes, she should be online.
She's online, is our fiscal analyst from the Financial Services Division. She's going to provide an overview of financial aspects for the SEB program. This is the presentation that was originally planned for March that got delayed and moved to this meeting instead. So Molly, welcome. We see you on the big screen. You're on the Jumbotron.
Oh, great. 3 feet tall.
And Molly's materials are behind tab 9.
Thank you. Good morning, Chair Birch and members of the board. Thank you for having me back. For the record, again, my name is Molly Christie, and I work in the IRB Finance Unit. And today I'll be revisiting the SEB financial overview that we presented before. Tanya usually gives this presentation. I think she's done it a few times in the past couple of years. This version is slightly different because we wanted to bring some additional insights that we track and give you a sense of some of the other work that we do, kind of tracking cost trend and other areas of our spending. So the slide that you see now is annual total medical cost for SEB compared to a national average. So what we wanted to do was get a sense of how costly it is to cover a family with children in SEB versus a benchmark. And what we found was that Milliman creates this annual benchmark for an average family of 4, and we thought it was a good opportunity to kind of see how a SEB family of 4 compares. So this includes what the family spends on healthcare, in other words, their out-of-pocket costs and monthly premium, as well as what the plan pays. So we've taken this high-level look at, this is specifically a SEB Tier 4 family on UMP Achieve 2. That is the subscriber, spouse, or state-registered domestic partner, and children. And then we've compared this to Milliman's hypothetical family of 4. And we have a few takeaways. If you look at the chart, and it's a very simple chart, and you can kind of see right off the bat that between 2022 and 2023, we did have an increase in our SEB spending for this average Tier 4 family. And it's about a 5% growth. It's not out of line with what we would expect year over year. It is consistent with trend kind of returning to pre-pandemic levels. Between 2020 and 2021, we didn't see a lot of change, but now we're kind of getting back into the normal swing of things. And then the second point I wanted to mention is that you'll notice that the average Tier 4 family in Achieve 2 is less costly than the average family of 4 based on this national data that Milliman used to develop this hypothetical family of 4. So in 2022, that's the last full year of data that we have. 2023 includes some projections. The average UMP Achieve 2 Tier 4 family cost about $27,000. You see that again in green, whereas the national average was just over $30,000. And this, it's hard to pinpoint exactly why this is. It could be due and is likely due to a variety of factors. Our population is going to be different in some ways from this national average. So we might be slightly healthier. We might just have a different mix of members and utilization. We also need to consider the cost of healthcare in our state and whether that is different than the national average. We have a very aggressive procurement strategy, so we tend to negotiate aggressive rates for our members. Again, so all of these things have an impact on the total cost of the program for SEB members compared to whatever benchmark we're using. What it doesn't mean though, and I want to just make this point before we move on, it doesn't mean that our plans are less rich or our benefit is less rich than a national benchmark. It just means that we actually cost less overall. Next slide. So this next figure shows the average monthly medical contribution breakdown. Again, we're looking at a Tier 4 family on UMP Achieve 2, and it includes the employer contribution, that's in light blue, the employee monthly premium in light green, and then the employee out-of-pocket spending in dark blue. When I refer to employer contribution to, I want to make sure everyone understands that's ADMC. And then the dark blue, when I mention employee out-of-pocket, that's co-insurance, co-pays, deductible, what you're paying if you get a bill after you go to the doctor. And you'll see that the employer, in this case, our employers Washington State, contributes approximately 76% of total monthly medical costs. And this might seem confusing. We're really used to talking about this 85-15 split, that's in collective bargaining. But what that refers to is the rate, the bid rate, essentially. So it doesn't include employee out-of-pocket spending, that dark blue portion. When we look at UMP Achieve 2 bid rate, we see that the employer is contributing 85% and the employee is contributing 15% as their monthly premium. We wanted this to be all-inclusive of costs, so we used an actuarial value calculator to approximate how much your average family is spending out of pocket per month. And when we compare the breakdown to, again, we're using this Milliman average family of 4 benchmark, and this average family is employed in an employer-sponsored, is covered under an employer-sponsored plan as well. We see that on average, our state is spending significantly more toward benefits for employees than this national benchmark. So we're at about 76%, and the national benchmark is around 58%. Next slide. We also looked at the specific cost drivers behind total medical spending in UMP Achieve 2. I will orient you to this slide first before I want to discuss the trends that we're seeing. So inpatient is in light blue, and that refers primarily to hospital stays. Outpatient is in light green, and that includes things like outpatient surgery. It also includes the emergency room. And then if there are associated labs and testing in those settings, that would be included under this bucket. Professional is doctor's visits. Those doctor's visits include specialists, behavioral health, primary care. That's where, most of the time when you go to the doctor, it's going to be billed under professional. Again, if there are associated labs and testing in those settings, that might be included under this category. Other medical is a little bit miscellaneous. It includes ambulance, durable medical equipment, including hearing aids, and then certain drugs can be billed under this category. Pharmacy is pretty self-explanatory. That's in orange. Those are your prescription drugs. And the two significant trends that we notice when we look at this, if we're looking at the left-hand side and we compare inpatient and outpatient, you can see that the inpatient portion of spend in blue is slightly decreasing over time. So that bar is getting a little bit smaller, whereas outpatient is slightly increasing. And this is a trend that we have identified prior to 2020. We obviously don't have that data for SEB specifically, but we know that there is a general shift for services, certain surgeries in particular, to an outpatient setting. So we would expect some of this, and then there were impacts of the pandemic as well that particularly affected that inpatient spend, and I'll dive into that a little bit on the next slide. And then the other point we wanted to make here is pharmacy in orange is increasing. Pharmacy trend tends to be on the higher end, and we did not see a contraction in pharmacy spending during COVID. So it's just continuing to increase, which is not unexpected. Next slide. I apologize first out, there are some labels missing, so I'll walk you through this slide. But what we have here, we digged a little deeper into select service trends that stood out when we were reviewing the data. And this is showing per member per month spending in UMP Achieve 2. And we have 3 select service trends. So on the left, you see behavioral health. The center is inpatient maternity. And then on the right is inpatient surgery. So inpatient surgery has the biggest bars. It's a higher proportion of overall spend. These bars do represent the proportion of spending. So you'll see like in the middle, inpatient maternity, those bars are smaller because they are a smaller portion of overall spend, but we're seeing some increases.
Molly,
Yeah, go ahead.
excuse me, it's Director Birch. So let me just make certain I heard you correctly. The furthest left stack is behavioral health. The center stack is inpatient maternity. Is that correct?
Yes.
And the last stack is inpatient surgery.
Correct.
Thank you.
And then the time period that we looked at, obviously, is the data that we have, so 2020 through 2021, or through the first half of 2022, H1 means those first 6 months of 2022. So it's not a complete set of data, but it does still give us an idea of where the trend is going. Looking first at behavioral health on the left. So we did see a dramatic increase in behavioral health costs per member per month between 2020 and 2021. This is in line with actually global trend for behavioral health. There was an estimated, the World Health Organization estimated an increase in prevalence of anxiety and depression specifically of around 25% in 2020. And they noted that it mainly affected or most affected women and young people. And we also, I did look specifically at any age bands for this data. We may mirror what we're seeing globally, but we definitely have seen an increase, and this is an area that we're going to be tracking more closely. In the middle, looking at inpatient maternity, we saw a slight decrease between 2020 and 2021, but in line with some national trends, we saw an increase for the first half of 2022. So we are seeing more births in SEB. We're also seeing this in the PUB population as well. And these things can be a little bit difficult to predict because family planning is complex, and a lot of cultural shifts and cultural changes can impact how and when people decide to start families. There was probably an impact of access to vaccines, remote work for a lot of people. This had less of an impact probably on the SEB population, which is why we maybe didn't see such an impact in 2021, because teachers are still, a lot of teachers were still going to work, and then of course in 2022 we're back mostly on-site, So a little bit different than we saw in the PEP population, but still consistent. And we'll be tracking maternity more closely as well. And then, as I mentioned on the last slide, on the very right, we see inpatient surgery. Inpatient surgery was really hit hard during the pandemic, so we saw a major contraction in claims between 2020 and 2021 of 21%. And then it slightly increased for the first half of 2022, but we're not seeing the rebound that we're seeing in some other areas. So this category of service may not fully recover, particularly as we shift more services to outpatient settings at the same time. Next slide looks at our risk profile. So we have SEB and PEB broken down by UMP and non-UMP. I've included PEB here because we use PED still as a benchmark for the SEB program because we have limited claims history for SEB. So it can be helpful to compare the two. And the PEB program, we do have our Medicare retirees in the PEB program. They are not included in the risk score because we do not calculate risk scores for our Medicare retirees. So risk score, you may hear us talk about this again in the future. I can always bring back this slide too. We can look at how risk is changing over time. So risk is a measure of how healthy or unhealthy a population is, and we use that to predict the expected impact to the cost of benefits for a group. So a higher risk group is costlier, a lower risk group is less costly. And we develop this score, we start by assigning a score to each enrollee, and it's based on several variables. So we look at this person's age, their gender, and then diagnoses, their actual claims for a specific period of time, so their medical and pharmacy claims, and all of that information gets compiled and is used to assign a score for that individual. And then that score is compared to an average 1.0 risk score. And on this chart, the average 1.0 risk is based on national data. So we use that as a benchmark, and we say this person is either below or above an average risk or average health. And oriented back to the chart, you can see that the risk score of 1.0, that cutoff is between the light green and the dark green segments. And blue represents low risk, light green represents below average risk, green or dark green represents above average risk, and then we have high risk and extremely high risk, and those are the smaller bars in purple and orange. And we can draw a few insights from this chart as well. Firstly, for all groups, we can see that there are more people below average risk than there are above average risk. So the bars, the size of the bars below that 1.0 cutoff are going to be bigger than the bars above that cutoff. And that is expected. That is how insurance works. When people are healthy, there are more healthy people in an insured pool than there are people who are unhealthy, and they help subsidize those who need benefits at any point in time. But what this does is it allows everyone in the group to access benefits at an affordable cost. We also see that the PEB program has a slightly higher risk than the SEB program. So the size of the bars above 1.0 are a little bit bigger in SEB or in PEB than they are in SEB. As I mentioned earlier, the PEB population does not include Medicare retirees, but it does include non-Medicare retirees. So that is probably driving some of this difference because that group tends to be slightly higher risk. They are an older age group and probably use benefits a little bit more than the rest of the population.
And Molly, this is Dave. Just a reminder, everybody, that all non-Medicare retirees, whether they're from state agencies, higher ed, or K-12, are in the PEB program. So you do see that dynamic of K-12 retirees, which in a different world, in a different pooling structure, might be in the SEB program or could have been in the SEB program, but all of them are actually in the PEB program.
Thank you. Yes. And then the final point that jumped out for us as well is the EOP populations are slightly higher risk both in PEB and in SEB. And again, this isn't surprising to us, but it is interesting to point out. Most of this is probably driven by UMP 2 and UMP Classic. These are, our biggest plans. They have the highest share of members in both programs for a single plan. And they're very rich. They have very broad networks intentionally. But that does mean that the plans are more likely to attract employees who may be higher risk or who have higher risk dependents because they expect to need to use those benefits. So we see a little bit of a difference there between those two groups. Next slide. So experience and trend is still a little bit, we're still developing experience, and we are still using that to kind of give us a sense of what the trend is going to look like in SEB. but it's difficult to assess because, and you've heard this before, we have limited experience. We have limited experience with the SEB population. It is still relatively immature, although each year gives us more information and more data to project. The total spending pattern, we use the net funding rate as a proxy, has not shown itself yet. We don't have a specific predictable overall spending pattern. What we have seen though is that if we use the net funding rate for 2021 projected through 2025, the average across that period is approximately 2.7%, which is quite low. We want a lower trend. Lower trend is typically better. It means we're not spending as much. 2021 and 2023 were really favorable years, and that is largely because we have this limited historical experience, so we were more conservative in our estimations. The projections for 24 and 25 are comparatively high, but when you're looking at very favorable years and then we have some relatively higher projections, those may look very high, but they are really in line with what we would expect for a trend pre-pandemic. And all that being said, we are also using PEB program experience, which is very reliable experience because we have such a long history. We're still using that as a proxy for the SEB program until we've developed enough baseline experience to use SEB-specific data. The earliest that would be is probably projections set in 2024. We want at least 3 good years, and of course the pandemic kind of threw that off a little bit. So that's something that we will assess next year, and we can bring that back as a talking point as well. And the next 2 slides should be familiar. These are slides that Tanya has presented in the last couple of years. This chart shows the breakdown in total spending for fiscal year 2023, and it looks really complicated, but the main takeaway is that the majority of spending in SEB is for medical benefits, and then of that spending, the split is about 60-40 between fully insured plans and our self-insured UMP, uniform medical plans. And then the total program spending is about $2 billion, which Tanya mentioned earlier today. And on the next slide, finally, we have this table which presents a snapshot of the SEB program's current financial position. It is a lot of numbers. I know you've seen this format before, but I will still walk you through because it's a lot. So at the top, you'll see that we're looking at accounting for fiscal year 2022 and 2023. Together, that makes up the biennium. And this is broken down by revenue, expenditures, and then our surplus or deficit position. Revenue is what you would expect. It represents the money that the program brings in to fund our expenses. So the largest component is the funding rate revenue. There are other pieces that you see in here. I'll note that investment income is interest earned on fund balances, so that includes things like the money that the program is required to set aside to pay for reserves. But overall, the total program revenue is about $3.9 billion for the biennium for that 2-year period. Expenditures is what the program spends on benefits. That includes our self and fully insured medical, dental, vision, life, LTD insurance. It also includes the K-12 remittance, which covers the subsidy costs for retirees who join the PEB program, as Dave mentioned. And then we have the HCA agency administrative costs, like our building, staffing, travel. There's a little miscellaneous piece in there. There's a footnote at the end that includes fees, open enrollment, litigation. It's a small piece. And then finally, this surplus and deficit position is the beginning fund balance that we have, plus the difference between total expenditures and revenue, and then the final loan repayment is listed as other financial activity. We also have the premium stabilization reserve. So you see that we have a beginning fund balance of about $153 million almost, minus the $11 million final loan repayment, and $9 million adjustment to the premium stabilization reserve due to increased claims, and a $46 million revenue deficit. If we deduct the target PSR, the target premium stabilization reserve that we have to set aside based on claims, of $52 million, that puts us in an ending surplus position of $52 million. And that is the conclusion of my presentation. I welcome any questions.
Dave here for two additional pieces of context on slide number 9. I just want to remind everyone that when the SEB program launched, there was a loan from the general fund for the startup cost of the program, and there was a multi-year payback. And so just wanted to remind what that loan was that Molly was referencing a few times. That multi-year loan, it's fully paid off at this point, but it still shows up in the biennial balance sheets because there was a payment in this biennium. But you shouldn't need to think about that startup loan, ever again after this. The last piece is $50 million. It is $50 million to most people is a lot of money. It's a very small amount in a $4 billion biennial appropriation. Claims can swing. Tanya will tell you claims can swing on a given month by $40 to $50 million. So that really isn't that much wiggle room. Sometimes we say, landing a plane on an aircraft carrier in the Pacific Ocean. It's $50 million seems like it's a wide net, but it really isn't in the context of the program. So I just wanted to remind people of that relativity because it is important. Even though to you and me and most people, $50 million is a lot. It's a small percentage in this budget.
Thank you, Dave, for that additional information. Board members, any other questions for Molly or Dave? And as always, you can reach out to any members of the staff. That's why they give you their contact information. So thank you. All right. With that, let's move on to our next agenda item. And Kristen Stoimanoff is here. She is going to provide the Smart Health update. Kristen is our wellness manager, and she's going to go over the Smart Health update with us. Her materials are behind tab 10, and I will just brag up Kristen and her team. I was able to join them last week at a statewide summit up in Linwood, and they played a pivotal partner role with AWC in a huge statewide healthy workplace summit. And it was really great to see all the involvement and the movement from community colleges and private business and all sorts of public and private entities coming together to not only kind of, they just really have a lot of work to do to keep building towards a culture of health and wellness. So Kristen, over to you.
Thank you so much, Chair Birch. Good morning, and good morning to the members of the SEB board. As Chair Birch said, I'm Kristen Stoimanoff. I'm the manager of the Washington Wellness Program, and I'm here to give you a Smart Health update. This is what I'm going to cover today. I'll start by telling you about the Smart Health transition to Secure Access Washington in October. Then I'll give you an overview of 2022 SEB employee Smart Health participation, including people's feelings about their best and worst areas of well-being, areas for improvement, and areas of strength. And I'll also give you Limeade, the Smart Health vendor's recommendations for how we can improve things for employees going forward. I'll give you some information on progress we've made engaging SEB employers. And then I'll end by telling you about our Washington Wellness Program evaluation and some changes on the team that will really help us serve the SEB population and employer population even better. So in October of 2022, we transitioned from logging into Smart Health the old way to logging in through Secure Access Washington. And if you're not familiar with it, Secure Access Washington is the state's secure single sign-on portal for external users. And it's currently used for Washington services like driver's license renewals, like unemployment filing, and it's used for SEB My Account. And it allows individuals to choose their own unique username and password and sign on to multiple services with one username and password. And all state external facing applications have to use Secure Access Washington. It's a standard of the Office of the Chief Information Officer, or OCIO, and in October, Smart Health came into compliance with this standard. So we did a lot of communications to help people get ready for this. We did posts in the Smart Health platform itself in mid-September and late September, letting people know this change was coming and what they needed to do to prepare for it. And we also sent emails to registered Smart Health users in mid-September and early October once it launched, reminding people via email, it's coming and now it's here and this is what you need to do to be able to log into Smart Health using SAW. We also created a lot of support materials. We created a really comprehensive Accessing Smart Health guide and then a quick start guide, and we put that on our website and linked in every single communication. We provided the Limeade email and contact number. We provided our contact information and the SAW support information in all of these communications so people could get to the right place to get the help they needed. And when we went to the benefit fairs in November, we helped people directly. We helped them get signed on. We gave them the information on paper. So we tried to do a lot to support people in making this transition. We did get some pushback. A lot of folks didn't want to use it. I will say there was less pushback and less friction among SEB employees than PEB because SEB employees have been using SEB My Account. Have been using SAW with SEB My Account since it started. So it's been a little bit easier for SEB employees, but still tough. Next slide. So this slide gives a snapshot of how SEB employees participated in Smart Health in 2022. Almost 20% of the eligible SEB population were actively registered in Smart Health. And of these, about a third participated in any activity and about a third completed the well-being assessment. And overall, on a 5-point scale, the satisfaction level was at 4.3. The first column under blue.
Kristen?
Yes.
Actually, you might be getting to this, so go ahead.
Okay. The first column shows the most popular activities in 2022 among SEB employees. Complete your well-being assessment was at the top. It's required to qualify for the wellness incentive, which I'll tell you about in a second, and it's also worth 800 points, so it's very popular. But people also joined and participated in a lot of activities. One was about go exploring your community, sort of taking a vacation from home. There were lots of resources about open enrollment, and that got a lot of traction. On the financial well-being side, check your credit score, and on the physical well-being side, have heart-healthy diet was really popular. When people reported through the well-being assessment survey where they were doing best, in the physical realm, smoke-free living and drinking moderately rose to the top. In the mental emotional well-being realm, positive relationships and self-leadership were very positive. And in work well-being, work meaning and job satisfaction were really high for school employees. And when we've presented to school groups in the past, that really comes through in our conversations with all school employees. When people took the well-being assessment and reported on the areas they needed support, sleep was a big one. I think that shows up for all of us, and maintaining a healthy weight. Managing stress and anxiety and energy level in the mental emotional realms, and then belief in company and square deal. And this is the feeling, square deal is the feeling that you are appropriately compensated for, recognized for, appreciated for the effort that you're putting in. And we've heard from school employees that especially during the pandemic, they felt like they really had to be on the front lines. They really had to be in person. It was scary, it was stressful, and didn't always feel like they got all the support they needed from their organizations. So we've seen this a few times, and it was interesting to dig into it.
So Kristen, what was the value of the incentive in total to SEB members?
Yes, so the incentive, you can pop over the next slide, Mackenzie, and I'll show some data about that. Oh, sorry. In order to qualify for the wellness incentive, which is a $125 either deduction to your health insurance deductible, or if you have a high deductible health plan, it's a $125 deposit into your health savings account. $125 each year if you meet the requirements. And the requirements are that you have to complete that well-being assessment, you participate in enough activities to get up to 2,000 points. And if you do it all by the deadline, you get that $125 incentive in the following year. And the deadline for most employees is November 30th. For new employees whose medical effective date is between October and December, that date is December 31st. So this slide shows participation trends kind of on those key areas over the last 3 years, and I just want to highlight a few things. Registration, those are the numbers who actually took the step of going into Smart Health, logging in, setting up an account, and all of the other numbers are based on the folks who registered for Smart Health. I showed you in the last slide that registration percent is at about 19%, almost 20. We're working constantly on trying to get it higher. But you see in the well-being assessment column, the second column, it looks like a huge drop between 2020 and 2021. That's a little bit misleading because in November 2019, as SEB was just about to come on, there was a big push to get all SEB employees on Smart Health. There was a financial incentive to have them complete their well-being assessment, and if they did it in November, they weren't required to do it the following year, but the numbers carried over. So those numbers reflect everyone who did it in 2019 plus everyone who did it in 2020. So it looks like almost everyone took the well-being assessment in 2020 and then much lower in 2021. And I just wanted to make sure you understood that drop. But what we're really looking at closely is that participated in an activity column, because that is an area where we really are trying to work hard. I told you about the SAW transition, and we believe that that transition to SAW caused some friction and caused some folks to not log in and participate in Smart Health after October. But a really big thing that we believe that's impacting this is there was a transition in April from the Smart Health Classic platform to the Limeade One, the new Smart Health experience. And it's a wonderful platform. It has a lot more opportunities for us to communicate with employees, to engage employers, but it required a whole new login process. It required people to start from scratch. And we have just been working real hard to get everybody from Limeade Classic onto Limeade One, but we still have a lot of work to do. So that's where we believe that drop occurred. Satisfaction has remained at 4.3 throughout, so nobody said they hated it as a result of these changes, but we still see lots of opportunities.
Just adding, Dave here, especially with the dual impacts of those two pieces that Kristen was describing, the transition to the modern platform and then layering on SAW. I know you'll be shocked. I'm not a procrastinator. I'm absolutely a procrastinator. Many of us are procrastinators. If you were waiting to sign in to do your Smart Health journey in October and November, you were really experiencing both of those transitions simultaneously, and can't underestimate how that could definitely show up in these numbers. So they were months apart, but for procrastinators like me, you experienced them at the same time.
Yeah, so there was double work to do if you were in Dave's situation. Thank you for that context. In terms of employer engagement, okay, so now I will go a little more quickly, but we have seen a lot of positive things. We've really gotten a lot of SEB employers engaged, and we think a lot of this has to do with the impact of Substitute House Bill 1363. This was a bill that acknowledged the significant toll that secondary traumatic stress has had on SEB employees, and it required districts to establish mental health committees and put policies and procedures in place prioritizing employee well-being. And our program has been invited to participate on committees to offer resources, and we've offered a lot of Smart Health resources. We've developed guide for educators, and we've had lots of opportunities to work with individual school districts on their own employee well-being. We've seen an increase in school districts reaching out to us. We've seen an increase in school districts actually going through the process of using our Smart Health Worksite Wellness Roadmap and winning the ZO 8 award, and that was the presentation that Sue presented at the Healthy Worksite Summit, which was really meaningful to folks. And we got a lot of meaningful, actionable responses to our program evaluation, which I will tell you about in a moment. Next slide. Okay, so Limeade made some recommendations for us based on the 2022 Wellbeing Assessment Report. I'll go through them briefly. They gave us recommendations around creating value for wellness coordinators, addressing burnout with a holistic lens, and driving smart health utilization. And we understand that our wellness coordinators are often really the gateway to all employees. We can only get limited information to SEB employees, but if we give good information to wellness contacts at schools and state organizations, they can share them with employees and get folks engaged. So we've created a wellness coordinator channel in Smart Health that they can participate in. We do ongoing training, and we try to give them resources as succinctly and easily forwardable as possible. In terms of addressing burnout, that really rose to the top in the 2022 Wellbeing Assessment Report. So Limeade has been working with us to give recommendations where we can provide support at the organizational, manager, and individual level. And in terms of that driving smart health utilization, which we really are working hard to do, we're trying to understand the data better and understand what the friction points are for people. But one of the things we're really working on is trying to drive people to Smart Health as a place where they can access many resources, not just about well-being resources, but there's a lot about your SEB benefits and other resources in Smart Health. So the more we can send that message, hopefully the more people will see the value. Next slide. All right, in terms of addressing burnout, we got organizational, manager, and individual level recommendations. I do want to highlight burnout goes hand in hand a lot with really high employee engagement. You saw SEB employees say they took a lot of pride in their work, they took a lot of meaning in their work, but they are showing up in above and beyond ways, and it takes time and energy away from themselves and their families. And if they don't feel like they're being fully recognized by their employers or getting back or able to decompress, burnout can ensue. So we're looking at giving lots of resources at multiple levels to address burnout. Next slide. And I want to very quickly end by telling you about our program evaluation. Smart Health is an important tool, but we use it to promote lots of wellness benefits and other benefits. So we, as a Washington Wellness Program, promote these benefits and work with employers, and we wanted to know how we could best support employers. Next slide. We used a 1 to 10 Likert scale, mostly quantitative questions, asking people about our services, our communications, our trainings, and we also asked people how we could improve each of these areas. Next slide. We had over 1,700 contacts that we invited to participate, including over 1,300 SEB contacts, because we cast a very wide net with SEB organizations. Few people are designated in the SEB group as wellness coordinators, so we have a wellness champion network we tap into. We also reached out to the benefit administrators and the wellness committee members who all have some role in wellness. Next slide. People told us they were familiar with a lot of our resources, and that they really appreciated the timing and the content of our communications and how responsive our staff is to them. In terms of opportunities, they need more support with some of our tools, a data dashboard that lets them analyze smart health participation in their own organization, as well as our roadmap that helps them see the journey to creating a good wellness program. And they asked us for different ways to educate employees about their benefits, so we're working on all of those. And finally, I want to tell you about a couple of team changes. We have 4 full-time health promotion consultant positions on our team, and we had a vacancy that's now been filled, and we've effectively doubled the capacity of our team to understand and address SEB organization needs. We hired Aubrey Bright as our newest health promotion consultant, who's supporting the SEB employers. And I want you all to know her name, because if you want to reach out to an individual who will help you, Aubrey's now your person. But Heidi Helsley is still on our team, and many of you have worked with her, and she's fantastic and will continue to help us support SEB. But she's also our team's communications lead, so she can see everything we're putting out through that SEB lens, which is so important to understand the unique needs of school employees. And we have 2 limeade contractors who help us with all things smart health and helping employers customize smart health to meet their needs. Okay, I have shared a great deal with you on a lot of topics. If there's time, I'm happy to take any questions or suggestions.
Thank you, Kristen. Board members, any questions for Kristen? And again, I just will really compliment this effort because healthy, well people cost us a lot less money. They're more productive. They create just such a better work environment. And so I think everything we can keep doing to build up the culture of health and wellness and prevention. What our grandmas used to say, an ounce of prevention's worth a pound of cure. I'm such a nurse. So anyways, I just think this is one of those areas that we just have to keep after, and I really applaud you and your team.
Thank you, Chair Burt.
All right, thank you so much. We look forward to getting next year's update on this topic. All right, we're going to move into our next presentation. Our agenda item is procurement and contracting update. Our very own Shauna Lang, who is our portfolio management and monitoring section manager from SEBB, is going to give us an update on some procurements happening in the SEB program. Shauna's materials are behind tab 11. And Shauna, thank you for joining us online. Good to see you. Oh, and you are muted. You are not muted. Maybe up in the right-hand corner. Try again. We cannot hear you. We see your lips moving. Well, maybe you should log out and log back in. The board members, just give us a minute here while we, have one of those unexpected little hybrid blips that we just always have to expect. Where every meeting has to have one. I'm just glad it's not a big power outage. Now they're going, oh, you jinxed us. And Dave, we should think about if Shauna can't join us, who would be her backup?
She's rejoining right now.
Okay. I just know it's going to work this time.
Can
Hi.
you hear me?
Yes, much better. Go ahead.
All right. Good afternoon, Chair Birch and members of the board. My name is Shauna Lang. I'm the section manager for portfolio management and monitoring. I'll be giving an update on procurement activities today. First, we are nearly concluded with our procurement for tax advantage accounts. This includes flexible spending arrangements, or FSAs, and dependent care assistant programs, or DCAP. The contract also provides assistance to the Medicaid program, as it serves a small population for members on the Compact Free Association or COFA population. The contractor is paid separately, and there is no PEB or SEB funds used for this. For this procurement, negotiations are wrapping up with the anticipated signature date early this month, and HCA has retained Navia as a parent successful vendor. There will be another 10-year contract beginning in January 2024, running through December of 2033. This new contract, next slide. The new contract will provide the same services as before, but we've added a number of additional features to improve the administration. There will be more detailed and customized reporting available through the new contract to better monitor activities. With the contract, we have also addressed the possibility of moving the HSA, or Health Savings Account administration, to our FSA vendor. Currently, all PEB and SEB HSAs are administered through a separate vendor whose contract is not with HCA, but with our carriers who offer high deductible health plans. There's currently no timeline for this move, but the possibility is built into this next contract. Seen as FSA and DCAP participants claim funds using their healthcare services documentation, this new contract also enhances the number of security features and requirements that protect against inappropriate disclosure. This includes one-day breach notification procedures. This procurement also reduces our per participation per monthly fee in overall savings of $200,000 per year. All right, for our second procurement is for Smart Health, our wellness program. So our Smart Health program encourages members to focus on all aspects of health and wellness with an incentive to earn a reduction in their annual health deductible. Our current wellness contract has been in place since 2014. Procurement and selection have been completed, and our very successful vendor is WebMD, which will be a change in vendors starting in 2024. We are currently negotiating the new contract. As negotiations with WebMD are underway, the signature is scheduled to occur this spring. The security design review and process will begin in February. Full implementation will begin after the security design review is approved. This contract will start in January 2024. Next slide, please. The change in vendor will have little impact on how members recognize and engage the Smart Health benefit. Smart Health name and URLs are owned by HCA, so members will be interacting with the portal much as they do under the current contract. Our new contract will provide new options for our members while remaining user-friendly. There are also improved security requirements within the procurement and contract. Next slide, please. Our third procurement is our accountable care programs, which include the UMP Plus plans. Current contracts expire as of 12/31/2025. The current benefit in the procurement will remain similar to the current benefit design in the current contracts. Main changes will be in the areas of financial, clinical, and quality models. Next. We are currently in the process of writing the procurement and will be releasing it this summer, followed by the ASB selection in the winter of 2023 to 2024. Contract negotiations will be held in 2024 and implementation in 2025. Go live for this contract will be 1/1/2026. The ACP procurement will focus on enhancements to clinical quality and financial metrics and the opportunity to identify other interested bidders who are not currently participating in the program. All right, are there any questions?
This is Dave, not a question, but again, some context. I think this is the first time that we've had a presentation about ACPs since we executed the amendment that extended the current contract through the end of 2025. We previously had that extension for PEB, but we didn't have it for the SEB program. So if that hasn't been shared at a public board meeting, wanted to make sure to, if you were trying to reconcile or remember when that happened, it was in the last couple of months where we were able to secure a contract amendment with the same networks to extend that product through the same timeline that the PEB contract had and now bridge us to this future procurement that Shauna has described. So if you remember being kind of questioning or wondering when extensions were happening, we won't have an annual extension question anymore. We know what the two programs are aligned on their contract durations under the existing contract.
Thank you for that, Dave. So Shauna and Dave, so much has matured around outcomes and data since we started the ACP program. When you talk about enhanced clinical and financial metrics, is that beginning to pull in some of those social metrics that we know are drivers of one's health outcomes? Or are we defining clinical metrics in the health care delivery model? Are we pulling in any of the other kind of social metrics that, for example, the community checkup is pointing us towards that are big impactors on somebody's health and well-being?
So I think that kind of goes back to what Kate was talking about, where we're starting to look at pulling in race and ethnicity data into our programs. And so we're looking at how we can incorporate that, but some of those models do look at that, but we don't have that data quite yet, but we are working on that, yes.
Great, because I know a lot is changing in the risking category too, as we risk people, where we're adding in other elements of social risk. Households with somebody that might be incarcerated, or households with known substance use disorder, those kinds of things. So I just hope that we keep that in mind as we keep modernizing these contracts.
Absolutely.
Great, thank you. Other questions from the board? Well, as always, Johnny, you're making some major lifts with these procurement modernizations and renewals, and shifting kind of our vendor partners. So thank you for all you're doing. I think with that, we are going to move to our public comment period. One thing I wanted to add that I forgot to mention, Healthcare Authority recently was awarded a Healthy People 2030 designation. We're the only state agency in Washington that has received this designation, but in large part with Kristen's work and the population health work that we keep layering in, it really helps show our progressive thinking about how we're eradicating Hep C, how we're providing good benefits, how these things really matter in somebody's overall health and well-being. So you'll see a new logo that is added to many of our promotional materials because it's a big deal. Every year, every decade, the government sets kind of goals to get towards a Healthy People designation, and we were really proud to hear that we earned that designation. So now we're going to go to public comment. If there is anyone on Zoom that would like to provide comments, and if there's anyone on site that would like to provide comments, and I don't think we have anybody signed in publicly here in person, and I'm being told we have one person online. What I'd like you to do, if you are virtual, I'd like you to click your virtual hand, and I think you've already done that to begin to speak. And I will just remind our presenters that we limit presentations to about 3 minutes, and staff are always available if we're going to go deeper into a topic. So let's go ahead, and Dave, I can't read that name.
Yes, Chair Birch, we'll go to Nathan Johnson. I do want Mr. Johnson to know one piece of information, and the board as well. We've received materials from Mr. Johnson related to presenting to the PEB board, but hadn't realized that you were also attending the SEB board. So the SEB board members haven't seen your materials yet, but we will send them after the board meeting. So sorry for the confusion. We were focused on the PEB interactions with the PEB inbox and hadn't realized for both. But I wanted you to know they haven't seen your materials, but they will see them. We'll send them after the board meeting.
So,
perfect. That's great. My name's Katie Johnson, and I'm a pharmacist at Tick Clock Drug in Colfax, Washington. And this year, around January, we started hearing from patients that they were getting messages from their Kaiser plan that their pharmacy choice was being restricted, and that they were going to need to use a Kaiser pharmacy. And we weren't aware of this requirement, and the patients weren't aware of it. And so since January, we've just been working with patients to try to figure out kind of how this change happened. And we've talked to Kaiser, and I've called into the Healthcare Authority too, to try to get the information about how it was distributed to patients. Because we even had patients saying that they called Kaiser to check that we were still an in-network pharmacy, and we're told that we were, which we are, but that's where it gets a little bit confusing for patients because we're an in-network pharmacy, but we're under the first fill program. And so patients are being told, yes, Tick Clock is in network, but then they don't tell them that they're subject to this first fill policy. And so now patients are having to transfer their prescriptions out. And we're in rural Whitman County, and so the closest Kaiser pharmacy is over an hour away. And so basically our patients are being forced to mail order, which a lot of them do not want to do. And they're being told they can't opt out. And so we've had people contacting Kaiser, the Healthcare Authority, they've contacted the Insurance Commission, legislators, and I think some of them have probably contacted the board as well. And so we were hoping to give a presentation on what this change that might have seemed like a small change that could be saving some money for the board, what it's doing to small local business and what it's doing to these rural patients' health care. I can let Nathan comment as well. So.
Thank you for those comments. So let's note on the record. Thank you for those comments, Katie. Let's please make that change that Katie Johnson was our first presenter, and our second now is Nathan Johnson. So Nathan, you have about 3 minutes to make your comments to the board, please.
Yeah, I just want to piggyback that it's not just it's the SEB and the PAD members that none of them knew that this mandate was going to go into effect in January 1st. Pharmacies weren't notified, and so we've spent hours upon hours trying to help our patients, where when they try to call a Kaiser pharmacy, that they're on hold for 45 minutes before they can talk to someone. That's what they're and so when I watched this video and the presentation on how Kaiser satisfaction, I'm wondering where those numbers come from, and if Kaiser is the one giving you guys those numbers, of course they're going to say that satisfaction's high by their members, and but I have not had one patient come into this store and tell me that they're satisfied with Kaiser mail order. One being relying on the mail to get their insulin that has to be refrigerated, their heart meds where if they miss a dose, they're going to end up in the hospital, seizure medications. The list goes on and on. And so satisfaction-wise, I don't see where those numbers are coming from. And so we're just asking you guys to relook at this first fill mail order Kaiser only, and ask your members if that's really what they're wanting and not getting it from Kaiser.
So Nathan and Katie, thank you both for your public comments. We hear you, and I know staff will be responding. I believe we'll push those slide decks out. I also chair the PEB board meeting. I'm just filling in today over here on the SEB side. I know staff will be following up, and I believe both boards will be revisiting this issue. And but thank you, and also thank you. I'm a nurse. Thank you first and foremost for the care management that you continue to do to make sure that our rural vulnerable aren't missing some of those doses. And we hear you for the extraordinary effort you've put in. And I can assure you that Dave and his team are reviewing this.
And we did include all of our contact information. We're more than happy to go over it more in depth with different patient experiences. There's been a lot of media coverage on it as well, and one of our local state representatives even put out a statement trying to help get Kaiser to reverse this decision, some sort of exemption for our rural patients, because it's really having an impact on them, especially a lot of the retired patients, because a lot of them receive special blister packing and stuff to help them take their medications.
Yes.
And it's a service that isn't offered to them, and so.
And also, I want you to hear that we've also been made very aware of some of the postal irregularities with rural communities not having some consistency around delivery and whatnot. So again, the team is on it, working with KP and the legislators. Dave, do you want to make any further comments?
Yeah, I just want to highlight that we don't normally do a lot of back and forth response and public comment, but I think it's important to just share a little bit of information, both with you, Katie, and Nathan, as well as the board and other members of the public. We are beginning our annual renewal process with the carriers. We'll actually talk about that more at the next board meeting, and then that leads into the rate setting process in June and July. And we do anticipate that Kaiser is going to provide information that we'll be able to share with the board and public at different stages because of the procurement process and executive session that will allow the board to look at this decision again if the board wants to. But we do expect that there will be information from Kaiser that isn't just assuming ongoing implementation, and will provide the information for that review for the 2024 board seat, for the 2024 plans. So we anticipate some more information about that in May and June, probably more likely the beginning of June meeting. But encourage both you, Katie, and Nathan to continue to monitor the board materials and seeing that this presentation, and you can always attend the future public comments as well to continue to provide context and information.
We will certainly do that, and please do not hesitate to reach out to us with any questions. We're here at the store every day, and we're happy to help any way we can.
Great, thank you very much for your input. Is there anybody else lined up in public comment queue? Okay, and none here in the room. So I'd like to close public comment at this time and make a few announcements. I remind members of the board and the public that our next meeting is May 4th from 9 a.m. to 1:30 p.m. with the same format of attendance, either in person or via Zoom. We love having you guys in person though, so please do come back and join us. Dave, is there any final comments or things that you want to note that we'll be following up on? Anything from you before I adjourn this meeting?
One more final piece. I try to do a preview of coming attractions. Sometimes it's harder to predict the future. The things I know that we'll be talking about and bringing to the board next May, a non-exclusive list, just the only things I'm positive will be there, is the legislature will have adjourned. We'll have a final conference budget to go through. We'll know what bills have passed. They may not have all been acted on by the governor at that point, but we'll know what the high water mark is for bills. Cade referenced that he'll also talk about implementation of several bills that have been signed and the work has begun. And then I just alluded to this a moment ago, but we'll begin setting the stage and describing the renewal process for the upcoming plan renewals for 2024. So those are just a few items that we know will be there.
Thank you, Dave. Board members, as always, we really appreciate your crisp attention and your involvement and your dedication to maintaining SEB. Dave and your team, you guys make this all flow and move, and thank you to the virtual gods that didn't create any power surges or. So with that, this meeting is adjourned. Thank you all.